A very warm welcome, a very good evening to all doctors, those who have joined us from India. Good morning and good afternoon to our joinees from the other time zones. So I'm Dr. Preethi of Dr. Agarwal Eye Hospital, and I thank Dr. Ashvin and Dr. Karpagam for inviting me over to moderate today's session of Dr. Agarwal's Clinical Education's Grand Rounds. It's being relayed live on Zoom chat, YouTube, and Facebook our channel. And we have a very interesting topic today. It's actually a debate on a very practical and a very important topic, which is laser pan-retinal photocoagulation versus anti-VEGF monotherapy in the treatment of proliferative diabetic retinopathy. And I take great pleasure in introducing our eminent speakers of the day. And they are Dr. Manoj Khatri and Dr. Jabeen. A very warm welcome to Dr. Manoj Khatri. Welcome, Dr. Jabeen, and a few words about our esteemed speakers. First, I would like to thank Dr. Manoj sir, who's our invited speaker for the day. Dr. Manoj is a principal consultant ophthalmologist and vitreoretinal surgeon, founder and managing director of iDocs Eye Hospital, Chennai. He is a senior consultant ophthalmologist and chief of Rajan Retina Foundation at Rajan Eye Care Hospital, Chennai, and a senior consultant ophthalmologist at Apollo Hospital and Westminster Health Care, Chennai. So after completing his diploma in ophthalmology and diploma of National Board in Ophthalmology, vitreoretinal fellowship from the prestigious L.V. Prasad Eye Institute, Hyderabad, he did his clinical and research fellowship in vitreoretina and uveitis from esteemed Shankar Nethralaya, Chennai. So Dr. Khatri has published several papers in peer-reviewed scientific journals, presented widely nationally and internationally at various scientific forums. He is on board as principal investigator and co-investigator of various drug trials in ophthalmology. And Dr. Manoj has been performing live vitreoretinal surgeries at various state and national level conferences. He is enthusiastically involved in training surgeries comprising of advanced vitreoretinal disorder to national and international trainees. And he's also an executive member of Governing Council of Vitreoretinal Society of India. Welcome again, sir. And we have our Dr. Jabeen nurse. She completed her diploma in ophthalmology from Stanley Medical College and DNB from RIO-GOH. She's worked for several years as a consultant and anti-segment surgeon in Saudi Arabia. And she has been with Dr. Agarwal Eye Hospital as a retina consultant for over 10 years now. Currently, she's heading the retina clinic at Anna Nagar branch of Dr. Agarwal Eye Hospital. A warm welcome to Dr. Jabeen, ma'am. And before I hand over for the day to our speakers, a few words to our participants who have logged on in all the three live channels. We want to have a very interactive session, so we welcome all your questions on to us through the Zoom chat, through the YouTube live chat box, and all these questions will definitely be answered towards the end of the session. First, we will go ahead with the debate by our speakers, and we will be answering all your questions. So I request all the participants to keep putting up their questions in the chat box. Now, all over to Dr. Jabeen for her presentation.
Good evening. Today, I'll try and present evidence to convince you that that PRP should continue to remain the mainstay of management of proliferative diabetic retinopathy, and anti-VEGF, while an excellent adjunct to PRP, cannot, as things stand today, replace PRP as the primary modality of treatment of proliferative diabetic retinopathy. So I'm going to speak in favor of PRP. So the early evidence for the efficacy of PRP in PDR came from the DRS, diabetic retinopathy study. DRS showed us that PRP reduces the risk of severe visual loss in eyes with PDR by over 50%, and greater benefit was seen in patients with high-risk PDR. It also showed us that 50% of patients with severe NPDR progress to PDR if left untreated. The most accepted mechanism of action of PRP is by the destruction of photoreceptors. Photoreceptors are metabolically the most active and the most numerous cells in the retina. So their destruction in the mid-periphery results in reduced oxygen consumption and consequent better oxygenation of central and inner retina. The glial scars formed by the laser also facilitate the diffusion of oxygen from the choroid to the inner retina. The relief of inner retinal hypoxia results in reduced production of VEGF and other cytokines, causing arrest and regression of neovascularization. Being a destructive procedure, PRP obviously has several drawbacks and complications. It's painful and stressful to patients. It requires a certain amount of patient cooperation, reasonably clear media. The destruction of photoreceptors results in the loss of peripheral and night vision, impaired contrast sensitivity. It can worsen pre-existing macular edema, cause fresh macular edema to develop. It can also cause serous retinal and choroidal detachments, which are luckily transient. So you must be wondering why I'm playing devil's advocate and listing out all the adverse effects of PRP first. Yeah, but there is a little bit of method in my madness. So in defense of my defense of PRP will be two-pronged. I want to show you why PRP, in spite of its adverse effects, should continue to remain the mainstay of management of proliferative diabetic retinopathy, and how recent advances in laser therapy have to a greater extent overcome the drawbacks of conventional PRP. There are several studies which have compared anti-VEGF monotherapy with PRP. Most of these studies have only a 12-month follow-up period. Protocol S of drcr.net stands out because it has a long follow-up period. They came out initially with the 2-year outcomes and later in late 2018 with their 5-year outcomes. And the interesting thing is that while the 2-year outcomes show a distinct advantage of anti-VEGF monotherapy over PRP, between year 2 and year 5, this advantage seems to diminish, so that by the end of year 5, the outcomes were more or less equivalent of the. So for the uninitiated, Protocol S of drcr.net was a multi-center randomized clinical trial to compare the efficacy and safety of intravitreal ranibizumab with PRP in the management of PDR. 394 eyes with PDR, with or without DME, were included in the study and randomly assigned to receive either PRP or intravitreal ranibizumab 0.5 milligram at outset and later in a protocol-specified algorithm. Participants, this is important, participants in both groups were allowed to receive ranibizumab for DME, which might be present at the outset or which developed during the course of the study. So the patients in the ranibizumab group were given monthly injections for the first 16 weeks. Between week 16 and week 24, injections were again monthly unless neovascularization had disappeared completely. After 24 weeks, injections were given monthly if neovascularization had worsened. At any point of time, the investigator at his discretion was allowed to give rescue laser to patients. For the patients in the PRP group, PRP was done at outset. Patient eyes were reviewed every 16 weeks. Additional PRP was given for any worsening of neovascularization. So intravitreal ranibizumab, as I've already mentioned, was allowed for DME in these eyes. So the primary outcome measure was change in mean visual acuity. At the end of 2 years, the anti-VEGF group, with an improvement in mean visual acuity of 2.8 letters over the PRP group with just a 0.2 letter improvement, showed a distinct advantage. The difference between the two groups was statistically significant. But at the end of 5 years, both groups showed a more or less similar improvement in mean visual acuity, and the difference was no longer statistically significant. So this graph shows us how the mean visual acuity improved dramatically in the anti-VEGF group, especially during the first year. So even in the second year, it was still a lot better than in the PRP group. At the end of 2 years, the difference was still statistically significant. But between year 2 and year 5, you'll see how the mean visual acuity decreased gradually in the anti-VEGF group while it improved in the PRP group. So that by the end of 5 years, the difference between the two was not significant at all. So to sum up, there was improvement in both groups with the mean visual acuity improved from 2032 to 2025 in both groups, and there was no statistically significant difference between the two groups. Peripheral visual field loss, as expected, was worse in the PRP group than in the anti-VEGF group. But again, you'll notice a similar trend. While at the end of 2 years, the difference was 372 decibel with a p-value of less than 0.001. At the end of 5 years, it was still statistically significant difference between the two groups, but the difference had lessened to about 208 decibels. So between year 2 and year 5, while the anti-VEGF group lost 273 decibels, only the PRP group lost only 97 decibels. While the peripheral visual field loss was expected in the PRP group, it was unanticipated in the anti-VEGF group and needs to be studied further. Macular edema also improved in both groups as measured by mean change in central subfield thickness. It had decreased by 153 microns in the anti-VEGF group and 48 microns in the PRP group at the end of year 2 with a 65 micron difference, which was statistically significant. But again, at the end of 5 years, the difference was only 31 and no longer significant. However, the incidence of fresh macular edema was definitely higher in the PRP group than in the anti-VEGF group. At 2 years, it was 9% versus 28%. Whereas at 5 years, it was still significantly different, but it had lessened a bit. 22% in the ranibizumab group as compared to 38% in the PRP group. As far as disease progression was concerned, the incident of the presence of neovascularization as seen in fundus photos and vitreous hemorrhage was not statistically different in the two groups. However, PDR, high-risk PDR, tractional RD and TRD involving the macular center were higher in the PRP group. But if you see the actual number of eyes which developed TRD involving the macular center, which would really affect visual acuity, was only 2 eyes in the ranibizumab group and 9 in the PRP group, quite a small number. So the incidence of endophthalmitis in the ranibizumab group was 0.5% as compared to 0% in the PRP group. You will remember that the PRP patients also received ranibizumab for any diabetic macular edema. So this is more or less the same as the international incidence of endophthalmitis, which is about 1 in 1,000 injections. But when you keep on giving several injections over a period of time, the risk of the eye developing endophthalmitis is obviously very high, or not very high, at least obviously higher. And we all know how catastrophic endophthalmitis can be. As far as systemic adverse effects were concerned, so there was no statistically significant difference between the two groups, but you will notice that the number of events is actually higher in the ranibizumab group, and you will notice a similar trend in every single study which has compared the two. Mean number of injections were 5.4 in the PRP group as compared to 19.2 injections over a period of 5 years in the ranibizumab group, considering the price of anti-VEGF injections. And this greatly increases the burden of treatment for the patient. Also, more significantly, while the number of injections reduced from 7.1 in year 1 to 3.3 in year 2, between year 2 and year 5, it continued to remain at around 3 injections per year. So there is a lack of predictable endpoint. You cannot say that treatment can be stopped safely at any point of time. The median visits over 5 years in the study were 43 in the ranibizumab group, almost double that of the PRP group, which was 21. Again, this adds to the burden of treatment. Patient compliance in the study was 66%. This in spite of extraordinary measures taken to trace out those people who did not turn up for appointments. We all know that in a normal clinical practice like yours and mine, the percentage of people who are non-compliant is much higher. So what happens to all these people who do not comply? So I came across this very interesting study which set out to find just that. So it compared the functional and anatomical outcomes of patients with PDR who were lost to follow-up for 6 months or more, the patients who had received PRP with patients who had received anti-VEGF monotherapy. So there were 46 eyes in this group who had received PRP and 30 eyes had received anti-VEGF monotherapy. So on the return visit, when the patient turned up after being lost to follow-up for 6 months or more, the mean visual acuity had fallen significantly in both groups, but it was more in the anti-VEGF group. It had fallen to 2187 as compared to 2054 before the patient was lost to follow-up, whereas it was significant in the PRP group, but much less so. The mean visual acuity had fallen to 2083 on the return visit after being lost to follow-up as compared to 2053 on the last visit before the patient was lost to follow-up. While the p-value was 0.001 in the anti-VEGF group, it was significant but less at 0.03 in the PRP group. More significantly, after the treatment of 1 year, on the final visit, The mean visual acuity had improved in the PRP group to 2054. This is almost as good as the mean visual acuity before patients were lost to follow-up, whereas in the anti-VEGF group, it was still down at 2166. So the percentage of irreversible visual loss was much higher in the anti-VEGF group as compared to the PRP group. NVD was not, there was no significant presence of NVD in either group, statistically significant presence on the last visit or on the return visit. However, on the final visit, the anti-VEGF group showed a 40% incidence of neovascularization of the disc as compared to 9.1% in the PRP group. NVI and as far as NVI and NVG were concerned, there were none in both groups before the patients were lost to follow-up. On the return visit, with the three eyes with NVI and one with NVG in the anti-VEGF group and none in the PRP group. On the final visit, there was a significant 4 eyes with NVI as compared to 0 in the anti-VEGF, as compared 4 eyes with NVI in the anti-VEGF group as compared to 0 eyes in the PRP group. There were 2 eyes with NVG in the anti-VEGF group and 0 in the PRP group on the final visit. TRD again, no statistically significant difference before the patients were lost to follow-up. On the return visit, 16.7% of patients in the anti-VEGF group as compared to 0% showed a tractional retinal detachment, and on the final visit after treatment, 33.3% had TRD as compared to just 2.2% in the PRP group. As far as presence of DME and NV and vitreous hemorrhage were concerned, there was no statistically significant difference between the 2 groups. So some possible causes of poor outcome in non-compliant patients in the anti-VEGF group could be a rebound exuberant reactivation of VEGF after anti-VEGF was withdrawn. Also, we should consider Crunch syndrome, which is actually the occurrence of dense fibrotic connections between the retina and overlying tissue after intravitreous anti-VEGF. This makes the identification of the plane between the retina and the overlying tissue difficult and adversely affects the outcome of surgery. So I'm coming to the second part of my presentation now. I want to show you how laser advances in laser therapy have overcome the disadvantages of conventional laser. PASCAL, has been around for a long time. With a single press of the foot pedal, you can deliver 4 to 56 burns. The exposure time is much lesser than conventional PRP. This is really significant because the lower exposure time means only the photoreceptors and the RPE cells are destroyed. There's no damage to any cells in the inner retina. However, because of the lower exposure time, a higher power is needed to produce equivalent burns. And is it as effective as conventional laser? Yes, but the number of laser burns required is much higher with PASCAL as compared with conventional PRP. And also laser dosimetry and the ablation area needs to be titrated against the severity of PDR. So these are statistics from a different study. I put them up just to show you how a larger number of burns with PASCAL will actually deliver lesser energy to the retina as compared to fewer burns with conventional laser. Here, 2,925 burns at a high power of 413 millivolts, but at a low pulse, with a low pulse duration of 20 milliseconds. With PASCAL, delivered 24.3 joules of energy to the retina, whereas a smaller number, almost half the number, 1,203 burns at a lesser power of 257 millivolts, but at a higher pulse duration of 200 milliseconds, deliver almost 2.5 times higher amount of energy, or 61.8 joules. So because of this difference in the amount of energy delivered, PASCAL produces lesser inflammation as compared to conventional PRP. This picture just compares PASCAL burns with conventional burns. The PASCAL can be applied rapidly, safe in a single sitting, less perceived pain as compared to conventional PRP. It's more homogeneous, equally spaced burns with improved lesion localization. And because of the shorter duration of location of the damage to the localization, damage is localized to the outer retina and RPE alone. PDR regression rates are favorable. Multiple treatments seem to have no effect on visual acuity. So lesser inflammation means lesser macular thickening and lesser edema. So now I'm switching over to micropulse laser. So this This micropulse laser, as we know, is being increasingly used in the treatment of macular pathology. So it's fairly new. Micropulse laser PRP micropulse PRP is a fairly new procedure. So this is micropulse is actually an additional feature of commercially available lasers. Here the laser parameters are modulated to achieve only the positive regulatory effect of laser. So the mechanism of action is totally different. There is no destruction of photoreceptors. Instead, as a stress-related response to laser, the RPE cells surrounding the laser spots produce heat shock proteins. These cause immunomodulation and trigger off repair processes and therefore normalize cytokine production. This decreases inflammation. So the mode of action of micropulse is actually a lot different. While a press of the foot pedal will deliver, say, a pulse of 200 millisecond duration in conventional laser, the micropulse laser will deliver a pulse envelope of 200 millisecond duration, say. And each pulse envelope consists of numerous micropulses, maybe 100 to 500 of very small duration, 300 microseconds, not milliseconds. And these are separated by normal gaps, by longer gaps of 1700 to 1900 microseconds. So actually the laser remains on only for about 5% of the pulse duration. So this graph will show you how with conventional laser, if you set the duration at about 200 milliseconds, power is distributed evenly within this duration, and the laser remains on during the entire duration of the pulse. Whereas with micropulse laser, when you deliver a laser envelope, a pulse envelope, the laser turns on and off several times and delivers very small micropulses with longer gaps in between the pulses. So this shorter duration of the micropulse and the gap between the pulses ensures that only the RPE cells are destroyed. The destroyed RPE cells, the gap caused by the destroyed RPE cells is filled within a week by migration of adjacent cells and later by new cells formed by mitosis. So basically there's rejuvenation of the retinal pigment epithelium. So this results in improved retinal metabolism and possibly reversal of ischemia. So interestingly, micropulse lasers produce no visible tissue reaction, and the effect of laser on cells cannot be detected by any existing imaging modality, neither FFA nor OCT nor fundus autofluorescence can pick up laser burns produced by micropulse laser. So there are a couple of studies which have studied micropulse laser PRP for PDR. One of these came way back in 2008. This was an uncontrolled retrospective consecutive case study of 99 eyes with disease ranging from severe NPDR to severe PDR who were treated with micropulse PRP. The median follow-up period was 1 year. Visual acuity remained unchanged at the end of the year. Disease regression was comparable to conventional laser. The treatment was extremely well tolerated with no complaints of pain, loss of vision. There was no loss of night vision or peripheral vision or accommodation. The response was more gradual as compared to conventional PRP. But this is a good thing because there was no marked contraction of neovascular tissue and the consequent tractional retinal detachment. No inflammation, so no new macular edema and no worsening of pre-existing macular edema. Before I go on to a more recent study, I will present this new laser delivery system, which is NAVILAS or navigated laser. Here, this laser tracks and accommodates eye movements. The machine includes infrared, color fundus photographs, and FFA. Both micropulse and continuous wave laser, single spot as well as pattern are available. The retina is viewed on a computer screen. This is extremely convenient. No contact lens is required, so it's very comfortable both for the doctor and for the patient. So treatment areas can be planned and fed into the computer. The computer importantly maintains a digital record of treated areas, which is particularly important as micropulse laser marks are invisible. This is a picture. You can see how it's viewed on a computer screen rather than with contact lens. This study was done in LDP. This was a randomized prospective control study. Small study included only 20 eyes of 10 patients with naive, symmetrical, bilateral severe NPDR or low risk PDR. High risk PDR was not included because of ethical concerns. So one eye of each patient was randomized to receive either PASCAL PRP or micropulse PRP on the NAVILAS. The follow-up period was 9 months. So The result was arrest and regression rather than complete disappearance of neovascularization. Actually, this is even with conventional PRP, though we aim for complete disappearance of PRP, what we end up getting is arrest or regression. So one of the eyes with severe NPDR in the micropulse group developed vitreous hemorrhage, but no new vessels were detectable. So it could have been a PVD-related hemorrhage, or new vessels could have been present in the far periphery and not detected. Secondary outcome measures, there is no statistically significant difference between the two groups in terms of visual acuity, low contrast visual acuity, visual field parameters, ERG, etc. However, there was statistically insignificant advantage in terms of low contrast visual acuity, visual field index, and scotopic B/A ratio in the STM group as compared to the conventional laser group. So this picture from the same study compares the right eye of the patient who received micropulse PRP and the left eye which received PASCAL PRP. You will notice how there are no visible laser burns at all in the right eye. So micropulse PRP has no pain, no treatment associated adverse effects. It can be repeated safely. So since it can be repeated, repetition might improve outcome measures. This has to be studied further. There is no treatment associated inflammation or macular edema, no preretinal fibrosis and contraction. Therefore, it's safer in those eyes with extensive NVE and a thick and partially detached hyaloid, where with conventional laser, these kind of eyes will progress to tractional retinal detachment. Because of the absence of adverse effects, it might play a possible prophylactic role in the management of severe NPDR to prevent its progression into PDR. So to sum up, and laser PRP has a proven track record of over 45 years, much lesser cost and burden of treatment. The diminishment with time of the advantages of anti-VEGF monotherapy over laser PRP, as noted in Protocol S, is something which needs to be viewed with concern and studied further. So laser PRP has better outcome in non-compliant patients. Efficacy is equivalent for both modalities of treatment. The newer lasers produce lesser adverse effects, and with laser PRP, there's no risk of endophthalmitis or systemic adverse effects. So my contention is that while anti-VEGF is an excellent and invaluable adjunct to PRP in the initial management of eyes with PDR and macular edema, to treat underlying PDR and vitreous hemorrhage and to facilitate VR surgery, there are many more indications. But anti-VEGF monotherapy as the sole modality of treatment in PRP should be only in very specific situations, like patients who cannot cooperate for PRP in eyes with hazy media, and I'm sure there are a lot more indications that Dr. Manoj will deal with. Thank you. Like this gentleman over here, we need to scrutinize all the evidence very carefully and decide on the best course of treatment for our patients. Thank you.
Thank you very much, Dr. Jabeen, for a wonderful talk. After listening to such a detailed scientific discussion on why laser still remains or still can be considered as gold standard, we are all eagerly waiting for the support to anti-VEGF by Dr. Manoj for PDR. And to all the audience, we have got very interesting questions coming up. I would like to invite more questions, and all the questions will definitely be answered after we hear from Dr. Manoj. Over to you, Dr. Manoj, please.
Thank you, Dr. Preethi. I hope
it's
visible.
Yeah, it's visible. Please go ahead.
Yeah, many thanks for the kind invitation for the entire team of Agarwal of Eye Hospital, right from Dr. Jabeen to Dr. Manjula, Dr. Preethi, Dr. Karpagam, dear friend Ashar, Ashvin, Dr. Atul, and of course Amar sir, the entire team for such a warm hospitality and a kind invitation. Though we are online, I can still say the reception which I received was quite warm. So here we are to debate, rather I will say we are not going to debate, we are just going to say how each modality of treatment complements each other. No financial interest in my talk. However, when you have a patient sitting like this in your OPD and you straight away want to advise therapy, though this patient also has diabetic macular edema, if you look carefully here, you always wonder whether something else can be done for this patient. Okay, you definitely wants to control PDR, that this patient has a frank PDR, no doubt about it, but something else can be offered as compared to conventional PRP. This is the only thought. However, you need to be very selective, as told by Dr. Jabeen as well, that you need to rule out any component of traction in these eyes. So that means we are dealing with a non-tractional type of variety of disease that is of primary importance. Traction can be handled, but the traction, make sure it is extrafoveal traction at least, or extramacular traction. So this was the point of debate when the researchers from drcr.net group told us, whether pan-retinal photocoagulation versus intravitreal anti-VEGF, mainly ranibizumab, can be as effective as for proliferative diabetic retinopathy. And Dr. Jabeen has already enumerated all the points. However, mind you, there is always a fine balance if you look at the disease per se between under-treatment versus over-treatment. So we should not be looking either at under-treatment as well as over-treatment. And over a period of time, with the advent in the recent 4-5 years of wide field imaging as well as OCTA, which is again a non-invasive type of modality, that means of OCT angiography, has given us a lot of insights as how we are going to manage these patients, especially in current day scenarios. Look at this patient again, beautifully done angiogram, non-tractional PDR, one foci of active neovascularization here, but so much of capillary non-perfusion area. Okay, you can straight away advise PRP, no doubt about it, but you can even buy some time and look with anti-VEGF treatment as well as what, how this eye fares. So if this patient, mind you, has a 6/6 vision with normal looking OCT of the fovea. So these kind of patients are still there in our clinical practice. If you look at them carefully, we can pick them up and decide. Why I'm saying so, we don't want a, PRP done eye looking like this. Though it's a very nicely done PRP, the PDR is under control. But again, I will say this is a very aggressive design. You don't want, some kind of a peripheral vision loss, or maybe PRP related complications happening this eye, which has a potential of 6/6 vision maintaining throughout their lifetime. So though protocol S has given us lots of insights, but in a real world clinical scenario, we need to be very pick and choosy about how we are going to plan for the treatment of these particular patients. Definitely tractional proliferative disease has to be taken care out, and it requires a separate modality of treatment, which we are not going to touch upon today. So we are in an era of new normal. Now COVID era is there. So what is a new normal? As compared to, as far as the management of PDR goes, there is nothing new, but we need to be little pick and choosy as we are, looking for the escape from COVID itself. So case selection remains a very critical area. Definitely metabolic control goes without saying. Compliance of the patient from the patient education. We are dealing with a blinding problem if not treated promptly. And also combination therapy of everything to, available in your armamentarium is here to stay. And needless to say that I'm going to say only with one modality of treatment. So this was the reason why over a period of time for a global agreement for all these kind of patient, drcr.net has done a lot of work, and a lot of work has been done from our Indian subcontinent people as well, which I will be sharing on the epidemiological data. The purpose here was to give the optimal treatment for the eyes affected with proliferative disease of diabetic retinopathy, and also encounter the complications associated with it, mainly diabetic macular edema, ultimately giving best response to treatment for the patient and giving a good prognosis. So we have to keep it in mind that we are dealing with a complex disease which has multifactorial factor problems. The combination therapy always is here to stay, because as diabetes stays for lifetime, the diabetic retinopathy also stays for lifetime, and custom-made approach for each individual patient is the way to go. We normally investigate with all these modalities, all of us do that, so I don't have to go in details. However, when you look on the treatment part, whether you're going to choose anti-VEGF as monotherapy versus as an adjunct to the PRP, we still have a lot to ponder about and a lot to think about rather than to debate about. So let's look at the prevalence, pathophysiology, how the PDR is evolving over a period of time, the treatments available, anti-VEGF versus PRP trials and their efficacy, and so on. So seeing a patient like this, who has active PDR in your clinic is nowadays, along with diabetic macular edema, is not very uncommon. I'm sure every day all of us sees these kind of patients, but we always, think that how the epidemiology or the prevalence and incidence of PDR or, diabetic retinopathy per se along with DME has evolved over a period of time. The burden of patient is increasing every year. A lot of data is available from Indian subcontinent as well. I was fortunate to be one of part of one of the landmark trials from Shankar Nethralaya. We used to call it as Shankar Nethralaya Dreams, which is still undergoing. And we have told our, the Indian people that, including the EFFECT studies, which was from Andhra Pradesh, that the burden of diabetic retinopathy is more in urban as well as in rural population as well. So we cannot just say, okay, urban diabetics only get this kind of a problem. Even the rural population, we need to think about it. So as and when we are evolving about the understanding of the disease, the treatment modalities are also increasing over a period of time, and we have a huge burden on our hand. And as what we see in 2015 to 2040, there is going to be a threefold jump. So we need to keep all these things in mind rather than just thinking only one modality of treatment. Why I say so? If you look at the PDR, over a period of time, what people have said in available today's data, that about 8% of patients are going to have some kind of active proliferative disease, along with diabetic macular edema is again 8%, and sight-threatening diabetic retinopathy is close to 12%. So this increases our concern as how we are going to manage this patient. Over a period of years, our understanding of pathogenesis has also improved. For initially, we just used to think, okay, blood retinal barrier and that's it. But over a period of time, what we see here is, though breakdown plays a very important role, there is a lot of inflammatory mediators which play along key role, like VEGF and PKC inhibitor, and also prostaglandin analogs and so on. But abnormality of the structural changes at the vitreoretinal interface plays a very key role. As we know that this is a well-driven pathophysiological pathway, that vasoconstriction and hypoxia is on one side. But if you look at the VEGF is one of the main modalities of treatment, whether it is PRP, or because in PRP also, what you're doing, you're trying to reduce the VEGF uptake. And also the vitreomacular traction over a period of time, which is going to happen. So again, this also has to be kept in mind. As far as VEGF and goes for the treatment modality of sight, we have dual advantage of anti-VEGF. It has some anti-inflammatory properties as well, or you can add a steroid. So on whole, that when you add a VEGF as a component for the treatment of proliferative disease, you're not only treating the diabetic macular edema, you're also treating the neovascular disease as well, because there is a lot of vascular modulation happens over a period of time. It's not that the vascular modulation doesn't happen. And we have seen in treatment, I will not say treatment name-wise, but patients who are on treatment for diabetic macular edema, say for a non-proliferative disease, their grade of retinopathy, like a severe becomes a moderate retinopathy, and the moderate retinopathy becomes a mild retinopathy over a period of time. So there is something called as a vascular modulation which is happening, and which we need to keep it in mind. Can we regress the stage of retinopathy? That is a very big concern and very big achievement if we can do that. As of now, there is not enough evidence, but the researchers are trying to find out, can we reduce the stage of, say, what we know PDR has, like DR has 5 stages. So can we go from stage 5 to stage 4, or from stage 4 to stage 3, something like that, which will be a very big boon for these patients, as well as can we reduce the capillary non-perfusion areas. So in short, this is about VEGF, but in either modality of treatment, whether it is PRP or anti-VEGF, we are wary about one factor, which is a fibrotic factor. These patients should be followed up quite closely. We should not achieve at any stage a fibrotic factor of the disease. If we are achieving that, the sooner we deal this fibrotic component, the better are the outcomes. PRP, no doubt, has stayed a mainstay of treatment for about close to 3 decades. There is enough evidence on that. I don't have to go in details of that. Dr. Jabeen has very nicely highlighted. Reduction of neovascularization is one of the major achievement with that. That is reduction in severe vision loss for close to 60%. And when PDR regresses within 3 months after PRP treatment, the vision prognosis is very good. We have seen some patients PRP done 2 decades, 3 decades back, still maintaining 6/6 vision. The visual, like the side effects have already been highlighted, so we'll just not waste our time on that. However, does it still have a role in today's scenario? Yes, it does have a role in today's scenario. If you have a good laser like this, as been highlighted by Dr. Jabeen, we have something called as a NAVILAS. Only thing is that the accessibility of NAVILAS is little challenging. In India, I think we have only 1 or 2 installations. But I had a chance to use these lasers twice on patients, and we had very good what you call treatment plan, which can be documented right from image capturing to FFA, and how we are going to laser, which are the areas you can avoid, the safeguarding of fovea, safeguarding of optic nerve head, and so on. And the collateral damage to the vessels is one of the major advantage. As you can see here, though this NAVILAS is showing the treatment for macular edema, but you can guide your treatment according to the choice of the area of interest wherever you want to give the treatment. Though we are talking about PRP, so let's focus on the peripheral area where it gives us the advantage of causing very minimum collateral damage. So as you can see here, this is the you can just mask the optic nerve head and the fovea. Even you can do the laser blindly. As I said, I have already done for 2 patients, had a very safe kind of a protocols are available. When you look at the periphery, they have added this as a new in their what you call laser setup. So all these pattern lasers can be, the collateral damage to the underlying blood vessels is very minimal, even in the periphery, and the traction component generating from it is quite minimized. So definitely NAVILAS like this, or a MICROPULSE, even MICROPULSE laser accessibility is a big issue. That's the only challenge. Not many installations are there in India. Though we have a MICROPULSE laser at Rajan Hospital, but the patients what we are doing is quite less. I don't know why this video is not playing. I think the videos are not playing on Zoom platform, so it doesn't matter. So I just wanted to highlight, which has been told by Dr. Jabeen, that the importance of MICROPULSE type of a laser or a NAVILAS type of a laser, definitely they have a role. PASCAL definitely has a role. But again, the only disadvantage of these modalities of treatment, one is accessibility. The second thing, your number of burns what you're giving to the retina are on higher side, and your retreatment schedules are slightly on the higher side. But the main advantage is there is very little collateral damage, and you can have a target specific damage. So now when we know enough about lasers, so what are the alternatives? The alternatives what we have is definitely only anti-VEGF. We cannot have steroid for this. And over a period of time, as we know, all of us know anti-VEGFs have evolved. It's in common practice now. There are certain studies which have shown us the importance of anti-VEGF. Protocol I was the first one, then Rise and Ride, and also the Protocol S, which told us that ranibizumab shows to be non-inferior to treatment along with PRP, and also when patient has a associated DME. So you have a dual advantage of treatment here. But the only hitch here is, over a period of time, this patient has to undergo multiple settings of injections, and I will say more than that, the monthly follow-up is the key. So even if you have patients who have undergone, say, about 6 injections, 8 injections, 9 injections, whatever number of injections, I will not say it's a burden to the clinic, because it's become a routine norm for us to see this patient every month, especially with OCT. But the only hitch here is the patient has to be at least on monthly or 2 monthly follow-up. So that is a challenge. And visual acuity definitely over a period of 2 to 5 years is superior in PRP group as compared, in anti-VEGF group as compared to PRP group. Again, the advantages and disadvantages have already been highlighted. But risk of tractional component is very low with anti-VEGF. If you are starting the patients with a non-tractional disease to start on with treatment, these patients rarely progress to a tractional retinal detachment. Maybe related to the vascular modulation or disease regression all on whole is occurring, and then that is an added advantage. So again, one more question occurs in all of us mind is whether you want to go for monotherapy treatment or combination in real world scenario. So the data is available, but how you take this data into the clinical practice. So that's the reason Protocol S study design was there. As we know, these patients need monthly injection, no matter, at least for 4 to 6 months initially to start with. That's what happened in Protocol S. 4 monthly injection, then every 4 weeks follow up till 104 weeks follow up. PRP was done at the same, at the baseline, and as and when required at the follow-up visit. So what they have told us, definitely there is advantage of visual acuity change, but the disease stabilization, that is very important. The disease stabilizes quite rapidly over a period of time when these patients are maintained on anti-VEGF therapy. Definitely there is a response to DME treatment. All of us know there is a good response, and we are not concerned about safety side effects. A lot of us are giving anti-VEGF day in and day out nowadays. So what are the advantages of anti-VEGF? Definitely better visual acuity, less field loss, less development of DME, fewer vitrectomies over a period of time, and already received by some patients. The minus points of PRP we have already discussed, so let's skip that. However, in both the groups, we should have few considerations in our mind always. Definitely anti-VEGF, first concern is monthly You have to have patients at least 1 monthly or 2 monthly injection. Cost definitely yes, but again with biosimilars and so many agents available, I don't think that is a very big challenge. The major advantage here is it also takes care of anterior segment neovascularization if it's going to happen in due course. PRP, I always tells even to my fellow consultants or to my fellows or whoever, even when I do it, I tell myself that PRP is an art. It has to be done very carefully. You need to know less. You need to cause less amount of collateral damage, also less amount of damage to the existing NBEs or NBDs and so on. It's slightly difficult in hazy media, and definitely PRP has to be done in one-eyed patients, especially when you are dealing. You don't do a trial run for these patients. And then next question comes is, are we thinking of anti-VEGF as an adjunct in these problems or PRP as an adjunct? So we need to form a baseline for each and every patient and selected individuals, and then start the treatment and so on. So if you have these considerations, then you are fine. This couple of photographs I've taken from some studies. This patient received anti-VEGF, showed a very good response, no doubt. Again, one more patient with anti-VEGF with focal traction, remained stable, showed a very good response. But this particular patient, the third patient, the anti-VEGF didn't work that well. So that means the neovascular disease or the hypoxia is occurring. So you need to add on either laser or add on anti-VEGF more frequently. And this patient, though the anti-VEGF worked quite well, over a period of time has developed NBD after 6 months follow-up. So again, when you stop short of treatment, this patient's close observation is the key. So these are the learning. So that means the anti-VEGF again is not a panacea. On the other hand, this patient underwent PDR, PRP for my, at our place, develop a vitreous hemorrhage with one shot of anti-VEGF. You see how and beautifully the vitreous hemorrhage clears. So what does it tell us? It tells us in real world scenario, both the treatment modalities goes hand in hand. Is VEGF alone effective or VEGF with PRP is effective? That's a lot of studies are there to guide us. Here, like one of such studies like Pride says that VEGF alone is anti-VEGF alone is effective. But if you look at over a period of time, then we need to have a combination of this. Same way, the Proteus studies, what does it tells us? That the neovascularization of the disc, neovascularization elsewhere, and neovascularization in total, reduction is better with ranibizumab group. But again, if you can add on PRP at some point of stage, or maybe a scatter PRP, something kind of that, where selecting the areas of non-perfusion will be a better option. Retinal functions definitely is compromised in patients who have received PRP, no doubt about it. Even if it is a pattern laser by PASCAL or anything, definitely there is a small amount of compromise on that. Cost effectiveness over a period of time, there are a lot of data available globally, though anti-VEGFs in India as a third world country, we have a very subsidized race. It has proven that if you look at the quality of life, because PDR happens in a very in working age population, and we have a long lifespan ahead of the patient. So the cost effectiveness of anti-VEGF, may it is monotherapy or a combination therapy, is very, very justified. Even in the Western world, they are saying it's justifiable. However, at every step, as I told you, we need to look for factors which are going to cause one, concern. For the major concern is, angiofibrotic stitch, which can happen in either modality of treatment. Even PRP can cause this. We don't want to see patients like this. This patient was received anti-VEGF somewhere else, and see the outcome here with anti-VEGF. And though we are able to successfully attach the retina, but we don't want to see patients like this, which can be easily managed with your laser or anti-VEGF in selected situations. So a careful assessment at every visit is very, very important. And our threshold of vitreous surgery is reducing. We are seeing, we are operating even 6.6, 6.99. If you see a traction, which is going to cause you problem, like something that this patient has fairly good vision, 6:12 vision with this kind of a multiplanar traction, I straight away took him for surgery, attach the retina. This kind of fine membranes with 6.6, 6.9 vision, you can plan for an early surgery because our threshold is decreasing, So, careful assessment of studying the OCT, like neovascular, this patient has a neurosensitive detachment here, and there is some amount of complex of subretinal membrane here. So this kind of fair kind of assessment has to be done at every visit. This patient received PRP elsewhere. As you can see here, the burns were quite close to the fovea. Straight away taking for surgery. No point in waiting for either modalities of treatment. Again, one fine traction, patient will do very well with the surgery. However, these kind of tractions, which are just the focal traction and macular edema, you can think of debate about pharmacotherapy as well as laser at initial stages. Again, one more patient with multiplanar traction. This is pre-op and 3-day post-op. You can see settles quite well. So these kind of elements have to be quite well taken out when you take these patients for treatment with either anti-VEGF or PRP. The last concern which I wanted to highlight it in either of the treatment modalities, what happens to the capillary non-perfusion areas or fluorescein leakage areas. As we see here in one patient, this is a patient who has been with me for follow for close to 10 years now. This is definitely has a macular ischemia with leakage here, but as you can see here, there is a lot of amount of capillary non-perfusion zone here. So which modality? You cannot do laser so close to the fovea, PRP, and you cannot give anti-VEGF also, thinking that the traction will increase. But over a period of time, you have to strike a balance, discuss with the patient, and then think of how best you can help these patients out. We don't have an answer. A lot of research is going on. And some people believe that capillary non-perfusion area decreases over a period of time if you keep this patient on a continuous anti-VEGF therapy. So what is the best way forward is custom-made treatment plan for each and every patient. Always look for systemic status, lens status, perfusion status, classification status, financial status, and I always say timely reviews are critical in either modalities of treatment. So fact about PDR, our disease understanding and the treatment responses are increasing and evolving over a period of time, and combination therapy is here to stay. A successful PDR management is not about injection, not about PRP, not about algorithms. It's a personal approach, what you give to each and every individual patient. We have a very less drop rate, and I think once you counsel the patient in the right way, you can go a long way. And blindness due to diabetes is always preventable. Diabetes is a disease which can all be controlled but cannot be cured. So same goes with retinopathy as well. So physician and good physician and good ophthalmologist can give the best care for your diabetic retinopathy patients. And don't forget the systemic status of these patients, especially the hypertension, lipids, and nephropathy, which will go a long way. So the overall management is the key, and better understanding of pathoanatomy and pathophysiology over a period of time is trying to help us understand the disease per se in a better situation. And most of these patients also need cataract surgery at some point of time. So you need to time the cataract surgery accordingly. Economics, I totally agree, play a very major role in our scenarios. However, thorough clinical examination and understanding patient needs is also equally important. OCT, by no doubt, has to be done at almost every visit. We don't even charge. Sometimes the patient cannot afford or they are asking for concession, but OCT gives us a lot of insight. So I still feel this is one of the important parameters even on follow-up settings. So to conclude, anti-VEGF definitely is effective in improving in vision in PDR patients and also stabilizing the disease. That is very important, but you need to select patients who have non-tractional PDR. You cannot have a traction component. Faint amount of traction is okay, but make sure foveal or macular is okay. That is one of the key take-home message which I want to give. Whether it is anti-VEGF or PRP, both have a role based on your comfort. First of all, the physician also has to be comfortable with the modality of treatment what you are going to offer to your patient. So I always say to all the clinicians who are involved, especially in management of PDR, you should see your comfort. If your threshold for surgery is less, you have a tractional component patient, go for surgery. If your threshold is not there, then you can manage these patients medically. You can buy some time in these eyes. That is the main advantage of treatment for PDR. It's not like AMD or any other thing where the patient is going to go blind. Here we can buy some time for the patient. PRP, no doubt, is associated with some complications, but again, it's still not in your dustbin or dump yard. Anti-VEGF over a period of time, especially with the evidence what biosimilars we have nowadays available, and it's going to be cost effective. And no doubt in post-COVID era, all these multinationals have to reduce the cost of the injections, otherwise they will not be able to sustain. So, and I think Agarwal Eye Hospital in India is one of the leading anti-VEGF users. So their cost effectiveness, I think, it should not be a major concern. As far as we are thinking clear in our mind, this will suit my patient the best. Risk of vitreous hemorrhage, TRD, and night vision, and also on, they are all debatable issues. But what I will say is case selection is the key, and then only we have to offer the best to our patients. Thank you very much for a patient hearing. I have a couple of cases. If time permits only, we'll go through it. Otherwise, just leave it like that.
Sure. Thank you very much, Dr. Manoj. That was a very beautiful, practical, detailed talk, and with a lot of good, beautiful illustrative pictures as well, and and very nicely summed up at the end. So we will first take up all the questions which have come up, sir, and then we will show the cases if you're okay with it. Shall I shoot the questions which we have received from the audience?
Please go ahead. Please go ahead.
Yeah, so I would like to get opinion from both the consultants who have spoken now. So the first question which we had is, in this COVID era, do we have any special precautions for the pan-retinal photocoagulation? Dr. Jabeen, would you like to answer this first?
Yeah, basically try to stick to LIO and minimize slit lamp delivery system, and use barriers. And I don't know, Manoj, Khatri, do you have anything to add to it, Dr. Manoj?
No, the only thing is that what we are doing nowadays, patients who need either fill-in PRP or maybe, for example, first-time PRP, we tend to do it in one sitting, though we know there are complications, okay, doing laser in one sitting, but you're not trying to, do it in 2-3 sittings. That is one. I recently did one-night patient who needed a PRP. There is no way out. So instead of doing 3 sittings, we do it in one sitting. In doubtful cases, again, COVID test should be done. And as rightly said, we are not encouraging a lot of slit lamp delivery system. However, in the flip side, if you want to buy some time, again, as I said, anti-VEGF in select situations you can still consider. But definitely, as far as laser go, LIO will be preferable.
Yeah. Then, since you were saying that you're trying to do it in a single sitting, or does it not increase the contact time with the patient? They say that 15 minutes is.
I'm not aiming for 2,000, 2,500 burns. So
Okay.
we are just for 1,200, 1,500 type of burn. So normally we stop short at 600, 800 burns, in each sitting.
Right.
We are not, it's kind of a 1 to 2 sitting, something kind of a PRP.
Okay.
The idea is I don't want to see that patient again and again in the clinic for that, risk of.
That's true.
And the PRP, the best part about PRP is I always tell everyone, or in fact, I also practice the same way. It can be added on any time. Let's practice to aggressive with PRP to start with.
Yes.
A bare amount of PRP, which is barely required.
That's true.
Always add on. So there is nothing.
Yeah, that's true. You can do a basic PRP and then buy some time and add on later. And even an anti-VEGF will buy us a basic PRP with anti-VEGF will buy us a lot of time. Maybe probably titers over this COVID period.
Yes.
Yeah, and the next question is the same in COVID in mind. Can anti-VEGF be followed by PRP, and what is the time gap you prefer? Dr. Manoj, would you like to go first? Like after a PRP, how long, means after an anti-VEGF, how long do you wait to give your PRP generally?
Suppose if it is let's talk about pre-COVID era when everything is normal. So give anti-VEGF and you can do PRP after 3 to 5 days safely. That's not a problem. And again, we will prefer a LIO. I still do a lot of LIO PRPs, though we have only green laser available in that. We have also yellow multi-spot laser. But yellow multi-spot laser somehow the only problem with that is it's not the the problem doing the laser. There is no endpoint visible. So sometimes you are using higher energy without.
Exactly.
So that is one major challenge. But in experience and over a period of time, you can understand that yellow laser works equally well. I totally agree with Dr. Jabeen. So that is the only challenge. The third thing is now when you want to do in this COVID situation, let's wait for one type of modality, unless the disease is very aggressive, like you're dealing with a NVG in a one-eyed patient, early signs of neovascularization in the anterior segment, then you need to be little aggressive. Otherwise, just do one sitting of PRP or one sitting shot of anti-VEGF and wait for 1 or 2 months and then take it forward from there.
Okay, Dr. Jabeen, you would like to add something to this?
Yes.
How long do you prefer doing a laser after anti-VEGF, like slit lamp and LIO, whichever?
Okay, so if I'm trying to buy time, basically, if there is diabetic macular edema, I would wait for the macular edema to settle. But in COVID times, that's a little difficult. So probably once I give the anti-VEGF and the DME settles down a little bit, maybe in about 2 to 3 weeks time, I would prefer to do the laser, because in maybe normally I try to do it a week or 10 days after giving anti-VEGF. If the patient has macular edema, that is when, so that the PRP does not increase any macular edema that might be present. But otherwise, we all know that normally anti-VEGF will control the neovascularization for about 12 weeks. So that's the kind of time you can wait. So in this COVID era, so maybe an anti-VEGF and then wait for 2-3 months before thinking of further anything further.
Okay. There is a concern in mind of all the youngsters who are doing slit lamp delivery system. Like when you give an anti-VEGF, you're creating a port inside the eye. After how long can you place the lens and do it? Like that's a question which has been asked. Like after anti-VEGF, after how long can you do a slit lamp delivery of PRP? Dr. Manoj?
There is enough evidence that most of the centers are not patching the patient as well after anti-VEGF. So the wound entry is just with 30 gauge needle. It's unless until you are given Ozutop injection, so you are a little concerned and patch the patient for a few hours. I have stopped patching for almost close to 1 year now, and there is nothing like that. The only thing is that I have seen a couple of eyes who have developed infection post anti-VEGF and taken second day for surgery for laser treatment. In some of these cases, you need to be following little aseptic precautions. So we found out in one case the gonio gel which was used was contaminated, and the patient developed a fungal corneal ulcer, totally a different problem together, which has been published as well in last year IGO. So you have to follow little aseptic precautions. But if the patient is from outstation, we get a lot of overseas patients. So we need to be a little more practical and aggressive. So what we do is second day PRP is totally justifiable with the slit lamp delivery system, provided you follow all your protocols. But ideally, if you think you have enough time, you have 3 weeks to 4 weeks of time to play with once anti-VEGF. So the standard teaching is once you've given anti-VEGF, you want to do a scheduled PRP, wait for 2 to 3 weeks, and then only take this patient.
Okay, thank you. And the next is, you had actually already answered this. They had asked, when micropulse laser is invisible to any imaging, how are you sure that it has any effect? Any other point would you like to add to this, Dr. Manoj?
It definitely has. Unfortunately, my NAVILAS and followed by I had a micropulse video which didn't play. I think on Zoom platform, most of the videos don't play. That's the reason. Definitely has a role. We are doing a lot of micropulse PRP. The only problem with micropulse PRP is you don't know what is titration. So what I always tell to myself when I'm doing laser or to fellow colleagues, that once you see one visible spot on the nasal retina, take it as a land, as your benchmark, that this is what I'm not going to go beyond this. As I always say, a PRP gives you a lot of time. So you do limited laser. Definitely fundus autofluorescence is one of the imaging modalities where you will see micropulse burns.
Right, correct.
Fundus autofluorescence is one of the imaging modalities which is a very underutilized tool, but it gives you a lot of valuable information. I have a couple of pictures. We don't have time, but I would have shown you. We had imaged these patients on fundus autofluorescence. So definitely, if you have access to PASCAL or a micropulse diode laser, nothing like it. It may be yellow laser, nothing like it. Definitely, it has a distinct advantage on laser on a conventional laser system. The only thing, even PASCAL laser requires some kind of coordination. So start with say 6 to 9 grades of burns. Start with a low grade setting. Don't go with a wide 24-30 burns, and try to do less damage to the adjacent healthy retina. So that is the key. But micropulse definitely has a role.
So, and a micropulse laser, in the absence of NAVILAS, how do you map out your areas? You use the vascular tree as landmarks. Wouldn't it be a little difficult?
No. So basically, what I have started doing right now is first you will have either a baseline angiogram or you will have a wide field OCT. So you will know the capillary non-perfusion area.
Okay.
I am going to target only the capillary non-perfusion area.
So as you complete, you just you record that this area has been completed.
So, yeah, and we always have a fundus photograph available with us. So none of them are without any fundus photograph. Then in your second or third sitting or the follow-up, maybe after 3 months, 6 months, then you think, okay, this patient needs an add-on therapy or something like that. So that is only the major advantage of wide field imaging. That's what I said. Studying the patient right from your clinic. First you have a wide field imaging. It gives you a good map. What areas you are going to target and where you are going to select the patients for laser or anti-VEGF. something like that. So I will.
This answers, yes, please, Dr. Manoj, you're about to say something.
Message is I will first target, or most of the clinicians world over are targeting first setting only capillary non-perfusion areas, and
Right.
then start on if required. Yeah.
Yeah, that is the other question which was asked. Would you prefer FFA-based focal laser in CNP areas alone, or a scatter of 2 to 3 sittings in very severe NPDR, early PDR? That is another question. Dr. Jabeen?
Yes. So initially, like he said, if the first sitting, you can actually focus only on those CNP areas, complete them during the first sitting, and in subsequent sittings, depending on the severity of the disease, the severity of the PDR, you can do more areas of, you can add on.
Dr. Manoj, your thoughts, please.
Yeah, so once you have maybe a baseline, FFA or baseline angio OCT, whichever is available with you, wide field OCT available is also available now. So first you target how severe is first you think how severe is the disease, whether the patient is one-eyed. Definitely there is no role for any kind of PRP, whether it is scattered or complete PRP in NPDR patient. There is no evidence and there is no good practice on that part. Unless and until you are dealing with a very aggressive patient or you are little concerned in the one-eyed patient, one eye not tolerated diabetic retinopathy, in that case and all the very severe NPDR, I will consider PRP.
Okay.
Point number 2 is, as I said, look for capillary non-perfusion areas, target that, whichever laser you have doesn't matter. And then on follow-up visits, you keep adding on. So like that.
Sure. So if I can.
Another take-home message is, even if you don't have a FFA, a good, careful clinical examination tells you a lot of insights on which are the areas which are avascular, which are the areas which are vascular. Look
Right,
for
the color changes.
Color changes. There are a lot many insights. So it's not that every visit we need an angiogram. A good, careful examination, both with indirect and 78D, gives us a lot of clues. So you can add on laser accordingly.
Yeah, that answers. There was one more question which was asking role of PRP or anti-VEGF in NPDRs in the absence of NVE. So I think from what Dr. Manoj said, he was not too much favoring unless and until it's a severe
On the contrary, I think
NPDR.
Atul also must be.
Please reiterate on that point.
Yeah, on the contrary, just wanted to highlight one more evidence-based proof which is going to come in near future, another 3 years time. I think Dr. Atul Dhawan must be aware of that. That lot of multinationals, including Bayer and Novartis, have given their trials for use of anti-VEGF in patients who have NPDR. This is, mind you, without diabetic macular edema. That's what I was telling you. Okay, and I have 3 patients with me who don't have active diabetic macular edema, but have stage 3 or stage 4 of retinopathy, that is severe to very severe retinopathy, and we are keeping them on monthly or frequent anti-VEGF treatment to regress the stage of retinopathy, and it does works. So Bayer and Novartis both have submitted their protocols to FDA, and it has been approved for clinical trials to give anti-VEGF monotherapy over a period of time for patients in regressing the stage of DR, because we are seeing DR in early age group. So the time will come, another 3 to 5 years, where we are also will be talking about regression of the stage of DR. You have a stage 4 patient, will be becoming stage 2. Stage 2 will become stage 0. Something like that is going to become a reality. So that has to be kept in mind.
But again, you need to keep on giving the anti-VEGF over a long period of time. Once you stop, because it does reverse, hemorrhages, exudates at all. But does it actually?
Over a period of time, you study this. Even you take pictures of your, 5 years, 7 years old patients, and you keep studying this patient. The vascular modulation happens very well with anti-VEGF agents, provided systemic parameters are under control. So the vascular modulation is when it is going to happen, and you are going to get regression of DR. Even if you see your PDR patients who have done PRP, well done PRP, the PRP, nicely done PRP doesn't look like PDR patient. There is no universe.
Yeah, that's true. That's true. You sometimes wonder whether the patient did have PDR to start with.
So the thought process, I think even I had my own concern when I heard about this concept over 5 years back through NEOVASCULAR group itself. I had a very big concern. Okay, why you want to give anti-VEGF? But when you understand the logic and see how the researchers are thinking about it, the vascular modulation doesn't happen in EMD. In EMD, you have a occult CNVM, you cannot make it a normal fovea. It doesn't happen there. But PDR, or for example, any diabetic retinopathy has the distinct advantage of, there is something else which is happening and we are missing out on that. So the understanding will improve.
So you mean to say that there is a role of anti-VEGF in regressing the stage of diabetic retinopathy
over a period of time. Over a period of time.
Over a period of time. And then there's another question which is like this: what is the preferred modality if there is an extensive hard exudate? What would you prefer? Would you prefer an anti-VEGF or would you prefer a PRP? Dr. Jabeen?
Pardon? What was the question again?
No, extensive hard exudates or exudative vasculopathy, what would be your first line?
Okay, this is...
Am I audible?
I mean, yeah. In macular, you mean? If it's not, if there is no DME, there's no maculopathy, then definitely I would think of anti-VEGF rather than Ozurdex. So if it is macular, if there are macular exudates, then definitely Ozurdex rather than anti-VEGF. Is it he's talking about, I can't put up that question. So is he talking about proliferative diabetic retinopathy or DR in general with?
No, that was a general question. Not specifying what kind, just the setting of extensive hard exudates.
Then yes.
Then or exudative vasculopathy, what would you prefer?
Yeah, Ozurdex rather than anti-VEGFs. If there is extensive vasculopathy.
Okay. And there's another question which is asking us management of NVE in a well done PRP. This even I've seen in my clinical setting, like with a very good PRP, a lot of NVE still persists. So what would you advise, Dr. Manoj?
Yeah, so basically one is the location of NVE. If the NVE is in periphery and not going to cause you much of a problem, the patient never had any vitreous hemorrhage in a well done PRP eye, just observe it closely. However, if the NVE is close to the vascular arcade and the NVE is going to have some kind, NVE always will have some kind of initiation or a fibrotic component along with it. So you need to be very careful in giving anti-VEGF for this. Then carefully look for skip areas. NVE will just not just like that. NVE is occurring because there is some hypoxic source is there. So look carefully for some skip areas. If you can add on PRP. Then the third scenario is where the NVE is causing traction and going to be dead. Again, look for retromacular traction. The first preference for any NVE is if not causing problem, close observation. But if it is causing problem, then only you think of giving anti-VEGF to surgery. You have only 3 options available with you. Add on PRP or anti-VEGF or surgery. But surgery in a non-traction eye, I will not touch just like that. But when you see this NVE is developing early fibrotic component and there is enough traction, 6/9, 6/12 vision, no, don't hesitate in going in surgery early for this patient.
And next question is this cataract surgery. Like for example, the patient is having a lower grade of cataract, active, moderate, severe NPDR. Would you always combine it with an anti-VEGF, or what will be your way of dealing with it?
So
just a severe or a moderate NPDR with NS2 or NS3.
Yeah, I have a couple of patients to show you as a case presentation in that similar kind of a situation which is very common. If the patient doesn't have diabetic macular edema, no injection. If the patient
injection, okay.
If the patient has, we need to be very careful in selecting this patient. Patient has, because a fair amount of OCT can be done even in quite a dense cataract. The patient has, and again, when you look at macular edema, rule out traction versus non-traction before deciding on any treatment. If a patient has non-tractional diabetic macular edema, then prefer injection. Definitely anti-VEGF has a role. But if you want to buy some time, you can even give Ozurdex at the time of cataract surgery. The second scenario is patient doesn't have macular edema and you are planning for a cataract surgery, then you can start with a pre-op NSAID. You can have other modalities of treatment. It's not that the anti-VEGF or steroid injections are only the way to look forward. And keep this patient on topical NSAID for a longer period of time, maybe for 3 to 6 months. So I have those kind of situations to share it with you. If you have time, we can just go through quickly. Otherwise, there is no time, then
Yeah,
we'll.
we are almost through with the questions. We have a few minutes to go, and definitely it would be nice if you can share some of the slides quickly, sir.
Two things I wanted
Can
to
we
say.
have in 5 minutes?
Dr. Preethi, two things I wanted to say.
Ah,
So one is that
yeah.
Patients with severe NPDR, I would still consider PRP. I would try to assess if how good the patient's diabetic control is. If it's not good, and it's not likely to be brought under control, the kind of patients who've had a long history, have never had their diabetes under control, then I would still prefer. And patients who are likely to be non-compliant, I would rather do a PRP, especially elderly patients where a little bit of loss of peripheral vision is not that important. I would consider doing a PRP. Also, and the other thing, if it's a mild, or, if it's early cataract and mild or moderate NPDR, if there is diabetic macular edema, I'd rather control the edema, give a couple of injections of anti-VEGF, control the edema before planning cataract surgery. Otherwise, yes, like he said, if there is no diabetic macular edema, definitely only cataract surgery. Go ahead with cataract surgery. But if there is diabetic macular edema, anti-VEGFs along with the cataract surgery, or like Dr. Manoj said, maybe an Ozurdex injection.
Yeah, that was very nice.
Yeah.
That was very nice. Dr. Manoj, can we have your case presentation for 5 minutes and then we can wind up?
Yeah, we'll just go through. This first patient had a cataract along with a diabetic macular edema, as we are thinking how to manage it, And when FFA, you see fair amount of leakage happening. This patient also had a component of central serous retinopathy. That's what I say, look the picture very carefully. Don't think this is a microaneurysm. And over a period of time, this was OCT. What you see here is this patient underwent with multiple sessions of injections with a focal laser as well to the CSR leak, and a cataract surgery. As you can see here, after 6 months, nicely looking retina, and you can achieve a 6/6 vision in this patient. So these are common scenarios what you see here. Again, one more patient with cataract. This patient had a ERM component, so you have to be little wary as what we are going to manage this patient. But again, you can fairly manage this patient and debate about it. I'm going to skip couple of cases because of lack of time. There's another interesting patient. This patient was from Dubai, and initially she was on monthly follow-up from Dubai with us. In April 2012, first I saw this patient. So this was even before protocol S and everything. But what I told in my mind is this patient has hard exudate plaque in the right eye and fair amount of hard exudates here. We continued her on treatment, and she also had a proliferative diabetic retinopathy in an obese patient with a poorly controlled diabetic. We continued her on treatment in form of PRP, and still at that time Ozurdex was available. 2011 was the time Ozurdex was available with us. And see, over a period of 2 years, there's a good amount of regression in both eyes, and see the vascular caliber of this patient, So the diabetic retinopathy grade also improves over a period of time. So this is the learning which I had about 7-8 years back. So that was the time when we were thinking. Another patient, very bad diabetic eye disease in one eye and fair amount of active disease in the other eye. You always debate as how you are going to manage this patient. They had an active PDR here. This is a classic case of our debate here for today. NVE here, diabetic macular edema. How are you going to manage? Are you going to go only with PRP or anti-VEGF? What will you do? And this is the angiogram. And these kind of patients, all of us see. It's not that it comes from only to the retina clinic. It's not like that. And I always tell my colleagues, you manage the patients unless until it becomes out of your control, then only refer. So what we planned is leave the left eye, leave the right eye. Left eye we planned multiple sessions of anti-VEGF along with laser. So what you see here, the traction started worsening over a period of time. There was a bump here. The focal traction started worsening, but I told my colleagues, be patient, this traction will give away because this is a focal traction. This patient also bled over a period of time in spite of a PRP and anti-VEGF bled, But again, we added on. And what you see here, once you be patient for almost close to 2 years, you achieve a near normal looking retina, So you cannot even imagine this patient. So the key message here is you need to keep this patient on frequent follow-ups, educate them. This patient was not a well-to-do from here, financially, but we helped them out with various combinations, permutations. So always tailor-made the approach, and you can still achieve favorable outcome. The last case in this kind of hazy media also, this is case we will skip. But what I want to tell you is we should be aware of complications and for either of the modalities of treatment. Again, this patient based out of Dubai, she was my patient initially, 6-6 vision at this stage. Okay, you see an active PDR like this with an early component of traction here. Okay, I just advise a careful pan-retinal photocoagulation and defer the cataract surgery. She had early cataract also. I said 6-6 vision, why you want to touch? Unfortunately, we, due to various reasons, we lost her to follow up, and she went to Dubai, and then she underwent PRP, anti-VEGF, and cataract surgery, all three. Okay, agreed, no problem, but there was a drop in vision. Patient unhappy, came back to us. You know, there was a macular edema at this stage. If you have done a careful PRP and not given anti-VEGF in this particular patient, you should have avoided all these complications of angiofibrotic switch. See what happens to the fovea now. The fovea started tenting. There is an inflammation from anterior segment because of cataract surgery. And by the time I get her fitness for cataract surgery, for vitreous surgery, this is what happens. We land up in severe drop in vision and fovea deroofing. So we should be very, very careful. And though after the surgery, we attached the fovea, everything went out well, but still the visual acuity remained only at 6.9. We were never able to give her 6.6 vision. So from 6.6, you go back, you know, so sometimes the decision making is not that good on our part. But as you see over a period of time with multiple anti-VEGF, see the vascularity complex, all this vessel caliber, it's improving. You know, so there is a stabilization in the DR progression, the diabetic retinopathy progression, though we are not very happy with the foveal outcome. So these are in gist what we learn from our each and everyday patient. And thank you very, very much once again for all the patient hearing and giving this opportunity and learning from you all actually, basically.
Thank you very much, Dr. Manoj. The last two questions which I would like you both to answer. There's a question which is like, which is the best way to detect fibrotic component in the area of neovascularization, Dr. Manoj?
Yeah, well, the first is a clinical examination. You know, don't underestimate the judgment of your clinical examination. Be very good with your slit lamp biomicroscopy as well as your indirect ophthalmoscopy, especially in patients with DR. The second comes OCT. You know, the moment you are seeing OCT, we have peripheral OCT is also available nowadays, so you can go up to the equator. There is no hitch about that. And even if OCT is not available, your clinical judgment, I always say, every time dilate this patient. Don't just see the OCT and advise treatment. Normally what happens is when these patients are on monthly or 2 monthly follow-up, we just see the OCT quickly, don't dilate and advise the treatment. Don't make that mistake. So even in a patients who are on follow-up, on regular treatment, still this can happen. So unless and until we dilate, do a clinical exam, good clinical examination. And third best way to document these patients is a fundus photography. A good fundus photography will give you a lot of insights. So like this, and whenever there is a doubt in your mind that this patient is going for something called as an angiofibrotic switch, then you try to think about other modalities of treatment at the very same setting.
Okay. The last question to Dr. Jabeen. How much time does it take for a new vessel to regress after anti-VEGF and PRP? What is your observation and experience? And should we wait for a complete regression? If not, how to follow up?
So after anti-VEGF, it takes about 2 weeks to regress, and then it remains regress for about 12 weeks. And after PRP, it's a little bit longer. I wait for at least 6 months after I do a proper PRP and wait to see how much the vessels have regressed before I think of adding on or giving anything else.
Okay. So last word from Dr. Manoj sir, any take home point which you would like to tell the audience before we wind up the session for today?
Yeah, I think all of us are very good clinicians here. So the only take home message as far as the management of diabetic retinopathy goes, take good points from the studies, but always think of a real world scenario, try for treatment for when it comes to the treatment part, and always try to offer best to your patients. Some patients will go out of the scope of our management at some stage of time, even in our hands, it happens like that. So don't hesitate to pass on to this patient to your peers or to your superiors who can do a better job than you. So that is the only take home message. Whether you want to do PRP, whether you want to do anti-VEGF, there's a sole discretion on that patient's particular problem, the pathology at hand, and take all the things into consideration before deciding on any kind of a treatment that will go in long, as a long hand to support the patient and benefit the patient in long run.
Thank you so much. Thanks a lot to all the participants. We have had around more than 150 participants on around 100 were there on Zoom chat and around 50 on the Facebook page. And thank you all for the patient listening till the very end of the session. Thanks for a wonderful discussion by Dr. Jabeen, and thanks for the participation by Dr. Manoj, who actually has every day one meeting, but still he was very welcoming and forthcoming to come and join us in our grand rounds. Thank you so much. Thanks to the AV team, and thanks to clinical board and Dr. Ashvin for having this session.
Manoj, and thanks.
Thank you so much. Thank you so much, everyone.
Thank you very much.
Thank you, Manoj.
Thanks, Doctor.
Stay safe, stay healthy. Thank you.
Thank you. Thank you all. Bye-bye.